Everyone. My name is Jessica Reed. I am the Quality Improvement Manager here at Maine Quality Counts, and on behalf of the Maine Lung Cancer Coalition, Maine Quality Counts, and our presenters, I'd like you to welcome you all here to our webinar today. This is funded through the Maine Lung Cancer Coalition, and it's truly working together to reduce lung cancer in Maine. Funding for this webinar is through, again, the Maine Lung Cancer Coalition, through the Bristol Myers Squibb Foundation, the Maine Cancer Foundation, and the Maine Economic Improvement Fund. So today we are really happy to have some terrific presenters with us, and we are going to be talking about determining patient eligibility for lung cancer screening with low-dose CT scans. We have with us today Dr. Akshu Balwan, Dr. John Kempler, and Dr. Neil Corson, them all to the side. As we come into their content areas, I'll introduce them a little bit more thoroughly and read a little bit of their bio for you as well. Just a few housekeeping slides to start. Webinar logistics for Zoom. Audio lines for non-presenters are currently muted. Please use the chat box for questions or comments throughout the presentation. Right now, what we're going to do is hold questions to the end. If there's some things that could have some quick clarification, Dr. Corson has volunteered to help with that, and we can answer those a little bit as we go along, but really want to give our presenters time to get through their content for you all. If you are requesting CME for the webinar and you did not sign into Zoom through a direct link, or you're watching as part of a group, please email at mlcc@mainequalitycounts.org, either during this webinar or immediately after, so we can track your participation and make sure you get your CMEs. Just quickly, today's webinar agenda, obviously the welcome and introductions. Dr. Akshu Balwan is going to talk about lung cancer screening, some guidelines, and determining eligibility. Dr. Kempler is going to, his content is around determining if that patient is too sick for lung cancer screening. And Dr. Neil Corson is going to talk about tobacco use and calculating PAC years, and then we have the questions and answers at the end. This is just a few QC slides that we're working to improve the health of everyone here in Maine. And if you'd like to connect with us, this is our email at mainequalitycounts.org. Speaker disclosures and CMA certificates. The speakers today do not have any relevant financial relationships with the manufacturers of any commercial products and or provider commercial services discussed in this CME activity. A CME evaluation survey will be sent to all of you after the learning session via email, so be looking for that. We ask that you please complete the Survey Monkey within 1 week, and then after that, a CME certificate will be emailed to you within 1 month completion of the survey. So today, I'd like to get started. So again, I'm very happy to present Dr. Akshu Balwan. He is currently the Medical Director of the Interventional Pulmonology Department at Maine General Medical Center. He attended Maulana Azad Medical College in New Delhi, India, and completed his residency at Johns Hopkins University Sinai Hospital in Baltimore, Maryland. He then completed his fellowship at Maine Medical Center in Portland, Maine. His learning objectives for this webinar include understanding the lung cancer screening guidelines, determining eligibility for lung cancer screening, and discussing lung cancer screening with your patients. So with this, we'd like to turn it over to Dr. Balwan.
Hello, thank you for joining us. I'm Akshu Balwan, and I'll be talking a little bit about lung cancer screening as soon as I share my screen with you. Jessica, can you confirm that the right screen is shared?
Yes, yep, you have your slides.
Okay. Is the slides or is it the presenter view?
It's the presenter view.
Okay, so we got to move that.
I'm sorry, no, it's the slides. Yep, you're all set.
Okay. All right. Again, welcome everyone. Thank you for joining us. I'm going to talk about lung cancer screening. I do not have any relevant conflicts of interest regarding this contents of this presentation. So today I wanted to talk a little bit about outline the problem, and then we will go into lung cancer screening guidelines and how to make sense of the screening guidelines that exist, and then how to put them into clinical practice and determining the eligibility for lung cancer screening. And there's another important aspect of it is discussing with your patients, and we'll try to touch on it at the end of this presentation. Next, so why do we care about lung cancer? Quickly, it is the second most common type of cancer seen in both men and women in terms of incidence, and it is the leading cause of death sorry, in both men and women for cancer-related deaths in United States. As you can see, it's at the top of the second columns. Another way Another way to look at it is just a picture's worth a thousand words, and it kind of shows you the scope of problem of lung cancer when you look at the mortality as compared to other cancers, and it is much higher. Just quick question, can you see my mouse or no? No? All right.
Yeah, we can. Yeah, we can.
Okay. All right. Is much more than any other kind of cancers. Even in women, it is one of the leading cause of cancer-related death. And I just wanted to put this slide out to kind of put it in perspective of breast cancer versus lung cancer. And we do have a very good screening effort throughout our community with mammograms for breast cancer. And we are trying to kind of talk about lung cancer screening on similar lines because it's a radiographic screening method. We have made some progress in terms of cancer-related death, but again, these slides just emphasize that how important, how big a problem it is, as well as how strongly it could be possibly related to, so strongly it is related to smoking. As you can see that we have seen some decline with smoking cessation, and this ties into our efforts with lung cancer screening, as tobacco cessation is the cornerstone for a successful effort for screening and reduction in lung cancer-related mortality. Why this problem, I would also like to highlight why this is more of a problem in our state as compared to national average and of about 59.4 per 100,000. Our state is about 15 points higher with a rate of 74.8 per 100,000 population. So we have a higher mortality related to lung cancer in the state. Why it is there is probably the higher incidence is there because of I'm sorry, I said mortality, but this is incidence rate. So higher incidence, and there's a lot of factors that play into why Maine has higher incidence. But it also highlights the fact that screening is very important for our state and our population that we cater to. Why? Just to give you another aspect of lung cancer versus other cancers is the stage at detection is different, and it makes a difference in lung cancer as to what stage you get diagnosed at. If you look at this graph with little people, you'll see lung cancer kind of stands out that most of the people are in the dark blue area there, which are diagnosed at a later stage, which is stages 3 and 4, whether curative intent therapy is not possible or less likely to be effective. And this is summarized in this graph from American Lung Association, where stage at diagnosis matters in terms of 5-year survival rate. And we will come back to keep these in mind for the later part of the discussion so that we can kind of see if and how screening can help. So this is kind of the background for why we need screening, and then just a quick slide on principles of screening as to for what a screening test should be, and we will try to make sure, and I will try to kind of tell you how lung cancer screening fits all these criteria, that it applies to individuals in a defined population. It should be used for asymptomatic individual who is at risk of a disease or for a disease. And then this should be a good test to distinguish between disease and not having disease. And overall general public health it should improve health outcomes. There should be adequate infrastructure, and it should be an acceptable test. You can't do a very invasive thing as a screening tool, and it should be cost effective. So in lung cancer data, looking at the mortality data, and this is old data from 1985, but it has not changed dramatically in terms of advanced stage disease. So if we could somehow change the detection from stage 3 and 4, where it's the most of the patients are diagnosed at, to stage 1 and 2, there will be a dramatic improvement in survival. And with this premise, a large trial was launched called National Lung Screening Trial. It was the largest randomized controlled trial of 53,000 patients, which compared serial low-dose CAT scans of the chest and versus chest X-ray, which was at the control arm. And this trial was the biggest trial that showed that lung cancer screening utilizing low-dose chest CT is effective. And subsequently, USPSTF made it its recommendation to recommend low-dose chest CT in high-risk selected individuals. For those of people, those who are curious about a little bit of evidence from this, so in this trial, 24% of people were identified to have positive screening, and one of the major um, um, discussion points is the false positives in this trial, rating up to 96%, of which was false positive. So we detected cancer, but we detected a lot of noise too. But the good thing was low-dose CT consistently detected more lung cancers as compared to chest radiograph, but detection's not everything. It detected them at an early stage, as you can see here, as compared to this SEER, Surveillance Epidemiology and End Results database. We did have a stage shift here, which kind of ties back with the slide we had seen. If we can change the stage from stage 3 and stage 4 to stage 1 and B, we can change the survival or the chances of survival. So usually we were seeing 15% at stage 1A, and in the patients who participated in the trial, about 50% were detected at stage 1A, which is potentially resectable and curable and improved survival. And this was seen in this study that patients who were screened with low-dose CT had an improved had a lower mortality rate as compared to chest radiograph, and you can extrapolate that to as compared to no screening method used. And therefore, there was a 20% lung cancer-related mortality decrease. Every interventions with complications, and the complications specific for lung cancer screening was most pertinent, in my opinion, were false positives, which is the 96% of the 24%, or most of the patients had some findings that lead to anxiety and other issues, or maybe lead to another procedures which might not have been done if the patient hadn't had a lung cancer screening, might impact quality of life, especially when you're having more PET scan and you find something suspicious, and might lead to overdiagnosis. But we have to remember that it did lead to increased survival, and it did actually decrease all-cause mortality by 7% as well. So coming back to the crux is who should be screened? That is the big question. So there are multiple modeling models out there. USPSTF used this model to kind of try to plug in data from big trials and small trials, and they put it in this model to try to figure out where is the best of cost benefit to the lung cancer screening. And well, they haven't shown this point that they chose, but on this graph, this is what USPSTF chose as 55 to 80 years of age, 30 pack year smoking history, which is 1 pack a day for 30 years, and about quit within the last 15 years, or an active smoker. So this point was chosen as the point of maximum return in terms of how many we need to screen for an acceptable lung cancer mortality. You can choose different thresholds, but those are not recommended, and you can see how it could increase the cost if you have to squeeze too many, or decrease the effectiveness if you increase the risk, decrease the risk too much. So all of these societies and a lot of people who are concerned about health of our population came up with their recommendation, and this is a summary slide of that. I'm hopeful it's legible to everyone watching this, but USPSTF guidelines said 55 to 80, and it's mostly the age difference between USPS and what CMS, which is a coverage guideline based on their evidence review of kind of the modeling model we reviewed, says 55 to 77, which means that they won't pay for it, but doesn't mean that we don't have evidence to support that it might be effective in that patient population. I am not going to read individual slides in the essence of time, but this point of this slide was to highlight the fact that some societies have different age group recommendations, but 55 to 75 is usually what's covered. What we suggest is 55 to 80, which would be covered by most commercial insurances, given it's a USPSTF guideline. And additional risk factors should be taken into account, but would be harder to justify. And we, as pulmonologists and public health and thoracic surgeons, we agree that these risk factors do play a real role, and sometimes we do take them into consideration when seeing patients who have had a positive nodule and for further evaluation. So the big question now is that defines people who should be screened, who should not be screened. Based on the NLST trial, I think there were only a couple of exclusions, which was unexplained weight loss, hemoptysis as kind of definitive signs of possible cancer, and they should not be screened. But I would say CMS says any signs and symptoms of cancer should not be screened, any diagnostic, and my general take-home point I suggest is anybody for which you have ordered a chest CT otherwise, they are not a screening candidate at this time. Just order the diagnostic chest CT. So if somebody comes in with possible pleurisy, or you would have ordered a chest CT, you should just go ahead and order the chest CT and reevaluate for screening. Life-limiting conditions can possibly be considered. If somebody has stage 4 disease, stage 4 cancer, they possibly shouldn't be screened for lung cancer at that point. Poorly controlled CHF with a mortality, with estimated survival in single digits over the next 5 years. Oxygen-dependent COPD is questionable, and I think Dr. Klemperer will touch a little bit on that in terms of who can undergo surgery or not. But my belief is most oxygen-dependent COPDs, if they're well controlled and stable, could be screened. And how do we screen? I think I'm running over a little bit over, but shared decision-making, just to touch a little bit on, is a process which is required by CMS, and we should inculcate in our practice, and we should talk to our patients about the risks, benefits, as we had tried to summarize in the preceding slides, and give them the alternatives and help them make an informed decision depending on what is important to them. And that's essentially our day-to-day workflow, but it's now mandated by CMS. There are some tools out there. This is from Sloan Kettering Cancer Center, and this helps you calculate the risk for individual patient. Other one is at shouldiscreen.com, very easy to remember website, but that can help you kind of give the numbers to your patient if they are curious about it. Again, to say smoking cessation is the most effective way to prevent lung cancer. And once you order the screening, you'll get a result somewhat like this, which will have discrete recommendations from the radiologist. Take-home slide is this, saying that, well, says 209 is the number needed to screen to save one life. Depending on where you are on that graph, anywhere between 200 to 400 is the number needed to save one life from lung cancer for low-dose CT, which is much lower than prostate, breast, and colon cancer number needed to screen. If you have any pertinent questions, I'll take them now. Otherwise, thank you for listening, and I hope I was in good time.
Wonderful. Thank you so much, Dr. Baldwin. We so appreciate your input and guidance with these guidelines and determining patient eligibility for these low-dose CT scans. At this point, I would like to introduce Dr. John Kempler. He is the lead physician for Cardiothoracic Surgery of Maine. He completed his general surgery and thoracic surgery fellowship at New York Hospitals, Cornell Medical Center, and Memorial Sloan Kettering. He has been in practice at Eastern Medical Center since 1999. His learning objectives for this webinar include identifying those patients in whom screening would be inappropriate due to comorbid medical conditions and understanding options for the high-risk pulmonary patients. So at this time, I'd like to turn it over to Dr. Kempler.
Thank you, Jessica. And you'll control the slides for me. So yeah, I'm going to discuss the question, is the patient too sick, too frail, or unexpected to really benefit from lung cancer screening, and how do we identify those, and who do we obviously rule out? Next slide. In the as Dr. Baldwin discussed, in the NLST, which was a massive randomized study, there was a general description in there that if patients were unable to tolerate therapy or unlikely to be able to complete curative surgery, that they would be excluded. We'll discuss that a little bit because I think that's the real gray area here, and one that requires more thought than some of the more obvious exclusion criteria. Limited 5-year survival, I think, would fall into the more obvious criteria as outlined if there is decompensated CHF or untreatable aortic stenosis or uncurable other malignancy, that it's obvious that 5-year survival is unlikely. It'd be inappropriate to screen that patient. The patients who are obviously so ill and frail looking, people on maybe high continuous O2 or just a lot of very bad comorbidities that even a trip to the CAT scanner would be a burden. I think most primary physicians and pulmonologists would forego screening in those patients. So I think there's some very obvious exclusion criteria, and then there's a few that are a little bit more gray, and I'll get into those in more detail during the slides. Who makes the decision as to whether a patient is capable or appropriate for screening? In our experience, and I think nationwide experience, this largely falls on the patient's primary care physician. As Dr. Baldwin had shown, there has to be a relatively formal, well, not relatively, it has to be a formal discussion or shared decision-making process with the patient and their physician or nurse practitioner regarding the risks and benefits and the commitment requirements to get into the program. It's not just, well, we'll get the scan, but it's a commitment for several years of follow-up, a discussion as to what would mean if something is found, and then there's the false positive discussion, where most false positives are, they're small nodules or things that are benign but require follow-up. That largely falls on the patient's primary physician, except in situations where the lung cancer screening program would be a closed one. What I was just talking about before would be, a quote, open one, where the primary physician or nurse practitioner discusses with the patient and then orders the scan through a accepted screening program. That's how our program works. That's how most of the ones in Maine work. There is the potential to have a closed program where a patient or their physician would see that somebody qualified, in appropriate age and PAC year criteria, and then just refer to the program itself for the shared decision making. And this has some relevance when we start talking about, is somebody too sick, because you do have to have some knowledge regarding who is too sick and not, and there's a need for some education probably in the primary care realm. Is a patient truly medically inoperable or can't tolerate surgery or other therapy that we'll talk about? That's the crux of the issue. And to really decide that, I would suggest, as I think most centers that have active lung cancer screening programs, that there's a need for true multidisciplinary input. And a modern thoracic surgeon would play a central role in that discussion, because surgery for early stage lung cancer, surgery is still, I think everybody would agree, the best option. It is the best chance for cure or disease-free survival. And in order to determine whether somebody could undergo potentially curative resection, it really requires the thoracic surgeon to be involved in the discussion up front, because there's more than just doing a lobectomy. There's sublobar resection, subsegmentectomies, and really having an understanding of what could be achieved based on the CAT scan, and their pulmonary function, medical function, etc., is key. I'm going to go over some of data that's evolved in recent years on our ability to operate on people who are quote high risk, people who in prior years and certainly 10, 20 years ago might have been felt inoperable up front just based on pulmonary function tests. And we also will discuss briefly that if a patient is truly felt to be a poor surgical candidate, that doesn't exclude them from potentially meaningful therapy. And SBRT, high dose focused radiation, is becoming a better option with results in some situations that are nearly equivalent to surgery. So I thought one way to look at this, in a real world kind of scenario is just to look at what we've done at our program and who we've decided is operable and what we found in our screens to date. Well, this isn't to date. This is from the first 3 years of the program, July 2014 to July 2017. We're actually up to 1,000 screens now, but in that first 3-year period at EMMC, we identified 13 patients who definitely had biopsy-proven lung cancer from the screening program. And that was a 1.6%, which was about half of what was found in the NLST, but they had a full 3 to 5 year follow-up. And now we're actually starting to see, as we get into the 1,000 plus screens, that we're well over 2, and we probably will approach what the NLST did. So in an active lung cancer screening program, you will be identifying probably about 3 to 4% of screens will have a definite lung cancer. And as Dr. Baldwin described elegantly, what we found mimicked what was found, which would be expected to be found in the NLST and other screening programs, is that the vast majority of the cancers identified are truly early stage. And you can see that here, 12 out of 16 at our institution, or 75% of them, were early 1A to 2A cancers. We get a lot of patients referred from the northern region, and St. Joe's Hospital and some of the other centers have quite active programs. And when we looked at all the patients referred and treated at EMC, that goes up to 35, and it was 77% was still early. So that we think that'll be borne out at any center doing a lot of screens, that you're going to be identifying early cancers in the majority. And again, just to reemphasize what Dr. Baldwin showed, this is an exact mirror image of what is traditionally seen, in that historically the vast majority of patients will present with stage 3 and greater, where we're seeing the vast majority in stage 1 and 2. So a mirror image in a lung cancer screening program. I mentioned that the data and discussion on high-risk resections is evolving, and it is. This is data from the large database, the Society of Thoracic Surgeons database. This was presented at one of the major meetings about 3 or 4 years ago, and then published in the Journal of Cardiovascular Thoracic Surgery. And what this shows is that these were patients who were operated on with predicted FEV1 or postoperative predicted DLCO less than 40%. So what that would mean is, if you say your right lung was 50% of your lung function, and you needed to do a pneumonectomy, unlikely in a lung cancer screening program, but just easy to understand. So 50% of your lung functions from the right, and you need to remove the right lung. If your FEV1 or DLCO is under 80, your post-op predicted would be under 40. And that's traditionally been a cutoff. And when I trained, and most thoracic surgeons trained, if people were going to be under 40, you almost excluded them regardless of how they looked, because it just felt that the outcomes would be so poor. So what this slide shows is that in a modern thoracic surgery world, particularly with the advent of VAT surgery, or it's video-assisted thoracoscopic surgery, or minimally invasive port access surgery, results are very acceptable. And particularly with the VATS approach, mortality is quite low, even when you get to 20 and 30 compared to open. So we're believers in this, and this can be robotic, this can be VAT, but the idea is that for high-risk people, you can get them through, but you stand even a much better chance to get them through with a minimally invasive or VAT approach. So we went and looked at our high-risk pulmonary resections here, and this is just to emphasize that you can operate in a real world in Maine on people who have very poor lung function. And not all these patients obviously are from the lung cancer screening, but it is recent data from our institution over the same time period. We looked at all patients who underwent curative resection for malignant lesions, and the only people who were excluded were this who didn't have both FEV1 or DLCO. It was out of 316 resections in that time period. We defined high risk as either FEV1 or DLCO or both under 40%. And next slide will show you that. This is just I can't point, but there were 75 patients who were high risk, and those were either because of one or the other or both. And during that time period, these don't match up exactly, but you can see that majority of our resections are done thoracoscopically, and I would say that the majority of the high-risk resections were done thoracoscopically as well. You can't do thoracoscopic on some cases due to technical factors or big bulky tumors or central involvement, etc. But our default, as most places, is to try to do it minimally invasively, and we think it matters for the high-risk resections. Next slide, please. It's just similar data. It's nothing more to learn here. Majority of cases being done by VAT. So when we looked at our own data and all resections, looking at low risk and high risk, mortality was, very acceptable. In all high-risk resections, 2.6%, and one of the patients actually died of something else 3 weeks later. But that's still a 30-day mortality. So I think this just bears out what the STS data shows. And the only deaths we had were in patients who the DLCO was under 40. People under FEV1 all got through it. Now, I won't say these patients are always easy. Their length of stays are sometimes longer. They struggle a little bit, but they are getting through it and ultimately, surviving and hopefully doing well and maybe cured of cancer. Next. And then just, we feel in our institution, and I think the other institutions in Maine would say the same thing that are involved with lung cancer screening, that we will now operate on patients with classic high risk or prohibitive risk on a regular basis with good results, and that minimally invasive surgery plays a significant role in this. I don't want to not mention SBRT because it is playing a significant role for stage 1 lung cancer, particularly for patients who are clearly high risk. And we see these people every day. They come to the office, 6 liters continuous O2. They're 80, well, if they're 80s, they won't be in lung cancer screening, but just people who just look ill, they've got other bad things, they're in a wheelchair, whatever it is, and SBRT is a very good option. The guidelines for SBRT are well spelled out. Next slide. In guidelines, NCCN. I won't go over this busy slide, but it clearly shows there that SBRT is recommended for people who are medically inoperable or refuse surgery after thoracic surgery evaluation. And that's key. That's what I was talking about earlier. There has to be a multidisciplinary approach. Surgeon, radiation oncologist, pulmonologist, and together we confer with the patient, and sometimes it's shared decision, and figure out what the best therapy will be. But SBRT is definitely in the algorithm. Next. That's it. Thank you.
I would ask John that question that came in on chat. I think that's a good one. I'll read it to you, John.
I can probably.
Unless you can see it.
Yeah.
Basically, the question is, if the PCP is the one doing the eligibility assessment, how can they determine this issue of operability before they order the screening?
I don't think they necessarily can. I mean, they can, you can call who you're referring to and discuss it. I think the key really is if we would probably suggest to err on the side of entering the patient if you're worried that they're inoperable. If that's what would keep you from, we would err on the side of getting them into to screening where there can be a multidisciplinary discussion that should involve a thoracic surgeon. I think, as maybe this kind of knowledge that, yeah, just because somebody's got terrible PFTs, for instance, they can get operated on. If that kind of knowledge gets disseminated, that would help. But I think would probably say err on the side if it's a pulmonary question that, well, they're just too much, their lungs are too bad to tolerate therapy. You may want to consider if they're otherwise reasonable health and can get to the scanner and are committed to doing the follow-up, that, well, get them in the program and let multidisciplinary team to figure it out. And again, these aren't big lesions we're talking about. Most of the times these are small stage 1 little lesions. And SBRT can be a very good therapy for a peripheral, small lesion, 3 treatments. And most patients, even if they're very sick, can tolerate that.
Thank you.
Excellent. Thank you so much, Dr. Kemper. I so appreciate you sharing your knowledge on this with us as well. So I'd now like to introduce Dr. Neil Corson. He is the co-lead for the Maine Lung Cancer Coalition. He is a physician scientist at the Center for Outcomes and Research and Evaluation at Maine Medical Center. His research experience includes work on depression in primary care, behavioral health integration, shared decision-making, and practice redesign. He spent almost 20 years as a family physician geriatrician in rural Maine and returned to school and graduated from the master's program at the Center for Evaluative Clinical Services at Dartmouth, now the Dartmouth Institute, in 2002. His learning objectives for this webinar include participants will be able to describe a process for taking a smoking history and the potential challenges of doing so. So at this time, I'd like to introduce Dr. Neil Corson.
Thanks, Jessica, and hello, everybody. And my friends here will help me with my slides. So just to quickly review, as we determine who meets the eligibility criteria for lung cancer screening as set by the U.S. Preventive Services Task Force and by Medicare, there's really 3 issues to think about. Dr. Balwan discussed the issue of being asymptomatic, that you wouldn't screen somebody who has symptoms of lung cancer, you do a diagnostic test. Dr. Klemperer talked about the issue of being too sick to screen, and obviously we just heard a lot of interesting information about that. The third is the amount of tobacco use is the other current factor that determines eligibility. And so in order to do that, we need to talk to our patients about their smoking history and determine whether they are at or above the threshold of 30 pack years. The relatively easier issue is for former smokers who still need to meet that criteria of 30 pack years. How long has it been since they quit? That's a relatively easier thing to calculate. You just want to make sure that it's not been more than 15 years. The reason is somebody who quit more than 15 years ago, their risk from their tobacco use has decreased to the extent that the potential benefit may not be there any longer. So this next slide gets into the why is it important to determine the number of pack years. And it's really, all of this is about needing to look at the risks as well as the potential benefits of any screening test. And the way we know that the potential benefit outweighs the potential risk is to know that the risk is high enough. In other words, the risk of cancer is high enough for them to be screened. So in the National Lung Screening Trial, which has really provided the evidence that has led to CMS paying for lung cancer screening and the recommendation from the Preventive Services Task Force, the criteria for inclusion in that study was 30 pack years. So that has really set that eligibility criteria. There may be enough risk with less smoking. We just don't have studies to tell us that yet. As you saw, I think it was Dr. Balwan had a slide that showed the various recommendations from a variety of national organizations that are quite similar but have some differences around the edges. And some of the recommendations at this point would even encourage people who have less than 30 pack years of smoking but have other risk factors, such as, let's say, secondhand smoke exposure or radon exposure, to be screened. We don't yet know, and we don't yet have good enough risk calculators to take the eligibility to those areas. Those are things that I'm sure we will learn more about, and I think the eligibility criteria we have now are likely to evolve over time. So there is, from our friend Carrie Medeiros, who is one of the lung cancer screening navigators in general. So let's see, the question is, primary care clinicians order screening tests all the time, examples being colonoscopy and mammograms. And so if they're being screened for other things, doesn't that mean they're probably well enough to be screened for lung cancer screening? I think part of this, as I read further, part of this is, shouldn't screening belong to primary care rather than going through specialty offices? That's a philosophic issue. I think, I was a PCP. We do cancer screening with our patients all the time, as Carrie pointed out. This being new, this being relatively complicated, which is why we're doing a 1-hour webinar just to review eligibility criteria. PCPs haven't totally adopted this yet. Part of the work of the Maine Lung Cancer Coalition over the next couple of years is to continue to work with programs, help PCPs understand the process, and hopefully adopt it as well. I would say that's certainly a goal of mine, being a PCP myself. So thank you, Carrie. All right, I'm going to go back and talk a little bit about smoking history. Now, those of you who work with patients have probably taken smoking histories before, and I'm not going to try to teach you in great detail how to do that. But I want to go over some general principles. The first being that, let's say you started asking your patients 10 or 15 years ago, how many fruits and vegetables were you eating per day? Memory is a tricky thing, and it's hard to remember back as far as we're asking people to remember. So there is going to be some uncertainty. I will admit in front of all of you that during my foolish years as a college student and even early in medical school, I smoked cigarettes some. How many pack years did I smoke? I have no idea, but it was certainly less than 30. I could at least tell you that. And I think that kind of uncertainty as you're asking people to remember their habits in the past is always going to be a challenge. So what can help you? One way is to think about taking the smoking history in relation to important events in the patient's lives. So do you remember if you smoked in high school? How about in college? When did you get married? Were you smoking then, when you had your kids? So sort of, certainly for my limited memory, it helps me to try to link things to other events that I remember. And then trying to, by going in some detail through sort of the timeline of the patient's life, whether they were smoking and how much they were smoking at some key places along the way, to do your best job of estimating, is this a person who probably reaches 30 pack years over the course of their lives or not? The other thing, and again, people who take histories from patients, how much do you drink per day? Many patients give us a range. I have 2 to 4 drinks per day. I smoke a pack to a pack and a half a day. It's probably not an unreasonable approach to assume that patients are trying their best to be good for their doctors, and that if they give you a range with a low end and a high end, taking the high end might not be a bad way to go. So just those couple of things, I think, are some principles to keep in mind as you're taking a smoking history. One other thing, and I think this has maybe become even more complicated lately than it used to be. Excuse me. I'm aware of more and more people who roll their own cigarettes, who buy packages of tobacco rather than buying them by the pack. We know that there's cigars, small cigars, pipes, et cetera, et cetera. So this calculator, which comes from the UK, allows you to take somebody who has used tobacco in a variety of forms and translate that into packs per day or packs per week, and hopefully to get a pack year kind of history from doing that. So you can see the web address there at the bottom, smokingpackyears.com. So really that is, thank you, Lizzie, we can go back, just leave it on that. So I think the important points are that we want to screen people who are eligible because they're at high risk. And what we know about high risk right now in terms of tobacco use is that we know that there's benefit to people who have smoked 30 or more pack years, are still smokers, or who have quit within the last 15 years, which means their risk is still high. And in order to find out if somebody has achieved that 30 pack years, you need to take a good history, help them with their memory, and if they are users of tobacco in a variety of forms, you've got a resource out on the web that can help you with this. We have a fair amount of time left for some questions from the audience, and so thank you for being part of this today, and we're happy to take on your questions. So Carrie has another question. I think this could be for any of us. What she says is, what have you found to be the best methods for screening and tracking patients? A manual sort of paper spreadsheet, an electronic spreadsheet, or the kind of tracking software that I know at least some organizations are purchasing or looking into purchasing. Given that the other two are actively involved in programs, I'm going to defer that one to you guys.
Well, I'll let John answer first because Carrie is part of our program. So.
Yeah, we have we've got a dedicated software, but it's not specific to the lung cancer screening program, but it's very similar to the commercial, to other ones that are out there. We use it for tracking other data as well, but I think you need I think once you start growing and enrolling, hundreds of patients, a dedicated software is pretty essential, I would think, because it gets complicated. There's there's yearly exams, there's 6-month follow-ups, there's people that get treatment early, get other tests, and in order to be able to then go back and look at statistics and quality, I think it'd be hard to do manually. Maybe not impossible, but I think having some kind of dedicated software, or at least, I don't know, maybe if you're very good with spreadsheets, that probably would work, but I think it has to be something computerized.
Yeah. Just to add on to that, there are more than a few companies that are selling products out there for the exact same purpose and the exact same reason, that it's hard to track spreadsheets. And well, it is a requirement by CMS to report the data to the ACR registry, but that's just reporting data annually as part of your imaging screening program. But for the program and for the clinicians on the program, it is important to not let things fall through the cracks. So it will be very important for each hospital that's offering screening to have either a program or a champion who can kind of control and ensure quality screening and things don't fall through the cracks, or kind of go in with coordinate with the larger program and use their database or share their database. It is the biggest, not the biggest, it is one of the leading issues that we are facing and other screening programs are facing. And we have seen screening programs close down because of this data issue. But I think there are solutions out there.
Yeah, I'd agree with all that. And we have a thoracic surgery navigator,
Mm-hmm.
and it's actually become too much for her to handle with other responsibilities. So we're hiring a full-time person just to help manage the data, because when you get over 1,000 patients, it gets quite unwieldy at times, and you don't want to miss things, and then it's medical legal as well also. So it can, as you grow, having a dedicated data system is really critical.
Yeah, I would say that as we've talked to programs all over the state as part of the Maine Lung Cancer Coalition, many started with an Excel spreadsheet for tracking, but found as soon as they were starting to do the second round of annual screening that it started to become challenging. I think my sense is that programs are looking for that sort of dedicated tracking software. So thanks. There's two questions out there. There's one that has to do with home radon exposure and screening guidelines. So what I know, and Dr. Baldwin, I'll probably ask you to jump in. We know that radon exposure is a risk factor for lung cancer. However, because that has not really been quantified in the context of the National Lung Screening Trial, it actually does not enter into eligibility at this point, which I think is a shortcoming of our current eligibility guidelines. Akshu, do you have any more that you might say about the radon issue?
No, I don't mean that was nicely summarized. Unfortunately, especially for Maine with a higher rate of radon exposure, it is a very important factor. And when I said that Maine has a higher incidence of lung cancer as compared to the national average, we don't know, but we can speculate that that might be one of the factors that is playing a role in that, as well as a higher smoking rate above national average as well. But we would love to see it, but there is no consensus right now that quantifies radon exposure. Some of the guidelines, we might be able to tweak it as a secondary risk factor, but how do you quantify what the exposure has been, and how do you get the insurance to cover that screening? So again, as mentioned, screening has to be also easily implementable and if cost effective to do it, but for radon, the data is missing.
And the other similar issue is secondhand smoke. We all know that it's a risk factor, but it hasn't been quantified and it hasn't been included in the eligibility criteria at this point. We're still learning. I mean, this is a brand new screening program, and I'm sure in the sense of sort of when it rolled out nationally, when the U.S. Preventive Services Task Force approved it and Medicare started paying. So I think we're at the beginning, and there will be changes over time. There's another question here. It has to do with, does CMS cover the cost for low-dose CT screening as part of preventive measures? Does it have to be linked with a specific diagnosis code? So there are I think there are codes that are required to use both diagnostic and procedure code. The good news is because it's recommended by the U.S. Preventive Services Task Force at a level B, and I can't specifically quote what that means, but level A and B recommendations have a high level of evidence behind them. What that means is there is no patient copay required for a recommended preventive service such as lung cancer screening. Can either of you give the codes that have to be used to bill for screening?
I think it's Z12.2, but I'm double checking and by logging into my clinical system, because the code usually puts up. There is, if you search your ICD code, screening for lung cancer is a separate code now.
And is the diagnosis
and I'm double checking.
Yeah, well, I bet we can somehow put that on the Maine Lung Cancer Coalition website and the Quality Counselor website to answer for people.
I will answer in text once I confirm. I'm just trying to go into a patient and make sure I gave you the right number. But if you search your ICD database for lung cancer screening, something should come up.
Thank you. That's good. I think we're back to Jessica to wrap us up at this point, unless are there any more questions hanging in there for us?
I don't think so. And is there any, from our presenters, is there anything that you would like to say, I guess, in closing to the people here on the webinar? Any last words, I guess, before we wrap up?
One thing I wanted to just add as to dovetail with what Carrie was saying about primary cares doing colonoscopy and other screenings. And I think that's a very relevant thing to kind of think in terms of, and kind of remember the slide kind of I was showing where the number needed to screen. I think we, as internists and as primary care doctors, we do reflexly do screening for so many things. And we should kind of make our effort is to make lung cancer screening kind of get it on the same level. But on topic unrelated to this, it is important to look back at those screenings too and see, should we be doing a shared decision making and kind of addressing those issues. Means a patient with stage 4 ovarian cancer should probably not benefit from a colonoscopy either. So it's kind of not to point at one malignancy or other, but I think it's important in this era to have a shared decision making process for everything we do. And at the same time, I would like to see lung cancer screening kind of take a place with other screenings where it's a reflex part of your annual examination.
Absolutely. That's a great comment. Well, thank you all. I want to just take again this moment to thank Dr. Akshubalan, Dr. John Kempler, and Dr. Neil Corson. We so appreciate and understand the business of your schedules and appreciate the time and sharing your knowledge with all of us. So thank you so much for joining us today. And thank all of you for joining us as well. We are just so glad that you've been able to join us. I want to let you know that this series that we're doing, recognizing the need for this education, is really important to the Maine Lung Cancer Coalition. And so this is a complete webinar series. So more to come, and you'll be seeing things come through your emails. But just want to let you know that the next MLCC webinar, we're going to be talking about integrating tobacco treatment along the continuum of care when we're looking at lung cancer screening from the PCP office to the lung cancer screening site. So really trying to take a different look around tobacco treatment and incorporating that into the lung cancer screening visit. So I hope that you'll join us, and that's going to be on February 27th. And you'll all be receiving information about that as well. Next slide.
Thank you, Jessica.
I think just in closing, we just want to, again, link you all to the website for the Maine Lung Cancer Coalition. It's very easy at the MaineLungCancerCoalition.org. And again, thank you all so much for joining us today, and have a wonderful afternoon. Thank you.
Thank you.
Thank you.
Bye, everybody.